Hello, everybody, and welcome to episode 70 of CCA's Medical Minute, presented by Kroger Health. I apologize for my my froggy voice this morning. I do have a bronchial infection coming back from vacation. I haven't been here in a while. I'm happy to be back.
You had too much fun. That's what's
up. Too much fun, but there's something down there called the Sahara dust. It literally, it's dust from the Sahara Desert that travels thousands of miles. And within about 36 hours, my dust allergy was in full gear.
Yeah, he was in the Caribbean.
Yeah.
All right.
I asked, and by the way, I asked the question there. The locals pronounce it
Caribbean.
Yeah, exactly. Yeah. So anyway, not that matters, but so I'm here today with my colleague Sherry Hughes, our community engagement director, and I'm really honored to have Dr. Ann Brown, our associate professor of clinical radiology at the UC College of Medicine. So she may or may not have heard of, but I suspect may have heard of our founder, Dr. Bill Barrett.
Yes.
He
Wonderful man.
He is a wonderful man. All right, we're going to talk to Ann today about some new breast cancer screening guidelines that have come out, and this one's always a tongue twister. It's United States Preventive Services Task Force. It's actually
well done.
Well, yeah. But the acronym is actually harder because then you get a bunch of S's and F's and P's and T's.
USPSTF.
Yeah, try that a couple times in a row. You will find it very difficult. But we're going to talk about this change in breast cancer screening guideline. It's a good day for my fellow employees today because I'm going to not talk as much. Generally, I talk their ear off. So it's good for them today. And Sherry's in a great position to help facilitate our discussion with Annie today. Sherry's a breast cancer survivor and also was a very important proponent of something called Ohio House Bill 371, which we'll talk about as well, that has kind of improved screening access for women, particularly with breast tissue, and hopefully will provide better outcomes as well, which is kind of what Cincinnati Cancer Advisors is here to do. So I'm going to turn it over to Sherry, but Annie, one thing I want to do after we talk about this change in guidelines and we talk about the USPSTF, I also want to kind of touch base on kind of my own perspective on that with prostate cancer when they changed their guidelines in 2017 and some of the effects that came with that, including lower testing rates. I don't know if that resulted in higher incidence rates, but certainly could. Yeah. And so I'm going to stop talking, I'm going to drink my water for a couple minutes, and I'm going to turn it over to Sherry.
We're going to have to get you some water. Okay. Dr. Annie, in 2016, the same organization, the USPSTF, came up with a guideline that said, okay, the age would be 50 to 74 for average risk women to receive their breast screenings. And I believe that was annually. But now, just recently, early part of May, there is a new guideline that has come down that now says women that are 40 to 74 should receive breast screenings, but every other year. And so everybody's talking about this. What is your take on this new screening and exactly what does it mean for women?
Yeah.
Yes. So this is confusing, and it's causing a lot of consternation, as you might expect. The original guideline change happened back in 2009. So before that, all of the medical societies were on the same page, along with breast cancer experts, that beginning annual screening mammography at age 40 for women with average risk of breast cancer was the best thing to save the most lives. Then 2009 came around, and the USPSTF came out with their changed recommendations, saying that no, the screening age should be pushed back to age 50, and then only every 2 years should screening mammography occur for these average risk women. And after that, the American Cancer Society also changed their guidelines, but they made it something different. Start at age 45 instead. And every year, they said, until age 55, then every 2 years. The American College of Radiology, my college, has always said age 40 every year with no stopping point. But like you said, the USPSTF has maintained throughout these changing guidelines that mammography need not continue past age 74. So now,
Yeah,
the guideline, they did partially reverse their changed guidelines to start screening at, instead of age 50, age 40, which I applaud.
Yeah.
But the every 2-year interval is a real problem for me.
That's concerning, because I'm wondering if that organization perhaps looked at the incidence rates for women being diagnosed with breast cancer has actually decreased over years. And I think it's because the women have been going and getting, their annual screenings starting, at 40, if they could, the at-risk women at least, have been always getting their screening starting at 40. I'm considered at risk because of my mom's breast cancer.
Right.
So now what does all of this mean for someone like myself who has had a mother or sister or, other close relative be diagnosed with breast cancer early on? Does it now mean that women that are at risk should start a little earlier than just regular average risk?
So the USPSTF guidelines are specifically for average risk women. So any women who have an additional risk factor for breast cancer, like yourself, this guideline does not apply. Okay. And that's important to realize, because that can make a huge difference in terms of what age you should ideally start screening. So when we talk about patients who are at risk, that's those patients who have a family member, first-degree relative with history of breast cancer, or multiple relatives with history of breast cancer, those who have a genetic predisposition, BRCA1 and BRCA2 mutations are probably the most well-known, and patients who have had chest radiation for Hodgkin's lymphoma and other cancer treatments, especially between ages of 10 and 30. Those patients are not being addressed by these guidelines.
So what does this mean? There's a lot of talk about all of this right now. And as you said, it has created a little bit of confusion, I think, in the minds of some women, because now I would suspect that women want to know, okay, is everybody on the same page? Are we all getting this at 40 now, or should be getting it? And that every other year, biennial, that seems to be a big concern that I believe women are talking about too, because you skip a year, like during the COVID, pandemic, there were women that weren't getting mammograms or any other type of, medical treatments and stuff. And then all of a sudden now there's a surge in cases, I believe, from what I've been reading, of more breast cancers in particular.
Yes. So the USPSTF cited the reason for the change in this guideline is that there's an increased incidence of breast cancer, specifically in younger women, and that minority women are having the worst impact, and their mortality from the disease is much higher. So in particular, Hispanic and Black women are being diagnosed with later stages of disease, and more often are diagnosed before age 50. Okay. So they are the target for this change in the guidelines. But the every year versus every 2 years is a big potential problem, because those patients are going to be the most negatively impacted by screening every 2 years. 2 years is a time frame in which, particularly for Black women who have more aggressive forms of breast cancer, like triple-negative breast cancers, 2 years can mean the difference between local, treatable disease and disease that's spread beyond regional lymph nodes, potentially to other parts of the body. And once it's metastatic, then we're talking about, treatment that's much more difficult to go through and won't be curative.
Well, and it's good. I mean, it's really good we have you here tonight. I can already tell that we're going to probably need to have you back. That's either the good or the bad news. It depends on how you view it. But we were talking offline, and I mentioned this to Sherry as well, even before you came in. But here's would be a real life example in my case. So when I was diagnosed in 2013, guidelines were different than what the Preventive Services Task Force revised them to in 2017, when they kind of cast a dim light in many ways on PSA testing, and part of their rationale was that men are being overdiagnosed or maybe overtreated. And so, here I am, who makes an appointment when I turn 50 years old. I make a slew of appointments because I just turned 50. Not symptomatic. I didn't go in because I had symptoms, and they found what turned out to be advanced prostate cancer. Didn't know that then because we didn't have the imaging tools we do now. But back then we would have known that I'm already in the water with metastatic cancer. And so here's a real life case where if I waited till I was 55, I would have never been 55. And so these things have real impacts. And and I say this for the benefit of my colleague Sherry Hughes, who's a recovering meteorologist, that there was a time not that long ago where nobody really cared that much about what the meteorologist said, because half the time it was wrong. That's not the case anymore.
They didn't think about all the times we were right.
Right. But there's much more precision around it now, and so that's the good news. And I think for the most part the same thing applies to medicine. But the problem is when these things change like this, the layman doesn't know who they are versus any other organization. The national news desks pick it up, and even if they say the name, that doesn't mean anything to anybody. And from a patient or consumer point of view, they just shrug their shoulders and go, okay, here we go. I don't know what I'm supposed to do. And even if this is well-intentioned, it makes this very confusing. And just a little bit of commentary, but almost piggyback on what you said, lives are at risk here.
Yeah.
And so I think we probably need to think going forward between kind of clinicians, kind of these organizations that kind of make guidelines, and patients. It's like a better way to communicate this so that people just aren't going, okay, great, 55, I don't have to, okay, 5 more years, I don't have to think about this, with a potentially bad outcome. So I think it's another reason why it sets up another episode for us to talk with you, because part of what we're here to do is to make the patient's journey easier through better understanding of what they're being told. And I think this can be a quagmire at times, quite honestly.
Yeah.
Very much.
Do you share a similar?
Very much so. And, I think I feel very strongly that women should be the ones to weigh the benefits and the harms of breast cancer screening and decide for themselves, not have someone decide for them. Much of what they are citing as the reason why to only screen every 2 years are these so-called harms of screening mammography, which is the discomfort of squeezing the breast, the potential anxiety of an abnormal result, a false positive.
I would say all of those things to me pale in comparison to a breast cancer diagnosis.
They do not outweigh
They don't.
saving lives.
Right.
And so all the medical societies and breast cancer experts agree that the way to save the most lives is to start screening at age 40 and every year for those with average risk. For those who have risk factors, starting earlier may be appropriate, and typically we suggest adding an additional test like an MRI.
Okay.
I also think before we leave that another factor would be, trying to get all of the screening. We have to remember that, when you're waiting a long period of time, I think then that's when you really kind of lose focus of the fact that something could happen, that you could get this kind of diagnosis. Yeah. So I'm thinking educating women, at younger ages, so that they will know these risk factors, and they will know that they do need to be screened earlier because we're finding more cancers earlier.
100%, Sherry. And I think there was a missed opportunity here with the new guidelines coming out to shed light on the importance of risk assessment, and that happening earlier, especially for women who are Black or Ashkenazi Jewish, by age 25 ideally, so that we can identify patients who should start screening sooner. And MRIs can start as early as age 25. Typically we recommend mammograms only starting at age 30, but every patient is different, and truly breast cancer screening is not a one size fits all.
Right.
tool.
Exactly.
Yep. All right. Well, there you have it. Dr. Annie Brown on record saying just do whatever the American College of Radiology says. Don't pay attention to these other people.
Talk with your doctor.
Yes.
Ask your radiologist.
Uh-huh.
Yes.
Well, we really appreciate you having out today, having you out today, and having you come out today because this is really just tip of the iceberg, and it pertains to a particular screening guideline. But I think it does open up the conversation about how we improve patient knowledge and understanding and clarity around what's being communicated by these different organizations. So,
and Steve, I also think once we can, kind of tighten up the whole talk around insurance and all that, that women will have, be able to make better choices for themselves without the fear of, trying to figure out how they would even get these, tests covered.
Mm-hmm.
And by the way, Cincinnati Cancer Advisors provides financial navigation services to its patients as well, all free of charge. Well, thank you, Dr. Brown, for coming out.
Thank you for having me.
We look forward to seeing you again, hopefully soon.
Yes.
And the sun is shining, even though it's a Monday, it's a good day. So thanks for being part of it. Thank you, everybody, for joining us, and we'll see you again soon. Take care.